Good morning. My name is Steve Forbush. I'm a physical therapist. I have a PhD. I own a company called Orthopedic Manual Therapy Instruction, and I try to use that company to educate physical therapists on how to be better clinicians and also have the opportunity to make people certified manual therapists. Work in the Mid-South. But right now I'm going to spend a little time talking about some patient care scenarios and some patient evaluation scenarios. I really learn a lot by doing patient cases, not only in my practice, but by talking about patient cases with others. And I've done a lot of phone conversations with people on cases. It's just always educational. It's just see how people think, what they do, how they come up with their answers. And so I have a patient case I'd like to discuss today. We have a few of these, so you can look these up. My website is orthomti.com, and my Facebook page also has OrthoMTI, at Orthopedic Manual Therapy Instruction. That's abbreviation, OrthoMTI. So let's get on to this case. So I had a patient come to me, college student, scholarship runner, female, about 5'7". She weighs about 125 pounds. She came to me complaining of hip problems in her left hip. For some reason, the last few months, I've had a lot of left problems and not very many right, and I'm not sure why that is, but that's what happens. Sometimes you get these runs on these things. Okay, so with this patient, they have been having problems since December. This is March when we've done this evaluation on this patient. And in that period of time, she was running, started having more and more problems with her hip, and she started having hip pain on the left side that hurt in her hip joint. So she actually pointed to the anterior groin area and said it's bothering her in that spot, and it hurts her in the back of the groin on the same side. And she was also having hamstring issues where it was hurting her near her knee on the lateral hamstring. So that's her complaint. Hurts when she runs. She's having a hard time running at this time. She's cut way back on running. She's doing cross training. So she's doing some biking and some swimming to get her aerobic condition to be there because she's a scholarship runner and track season's just underway and she wants to be able to contribute to the team this year. She's a freshman, so they weren't counting on her for a lot this year, but she needs to be doing it. She needs to be doing her things that she needs to do to get better. Okay, so that's where she came in. Has no injuries, did not have anything happen while she was running. She started noticing it when she was doing a track workout, but nothing in particular that bothered her. She started having a little discomfort when she ran. She went to bed that night. The next day when she got up, she was worse. And so she had a hard time running that day, and it's been progressively the same or worse since that time. Now, she's a scholarship runner, so you know that I don't work for that university. So she's been seeing the athletic training staff. And the athletic trainers have been treating her with heat and ice and stretching and cupping. When she came to see me, she had cup marks all the way down her thigh on the left side, from her hip all the way down to her knee. They've done some dry needling. I don't know where they learned dry needling. That's sometimes amazing what sometimes I find that athletic trainers are doing, but that's something they were doing. And she has gone to an orthopedic doctor. So they weren't getting anywhere, so they sent her to an orthopedic doctor who did some series of MRIs on her hip and found that her left hip had a little bit of a pincer problem. So she had an overgrowth of the acetabulum on that side. They didn't check her right hip. They only checked her left. And the doctor said that it's a surgical condition, and if she wanted surgery, she could have it. She didn't want surgery. So that's where we're starting. Okay? Came in the clinic, walking without a limp in normal gait. We didn't run her the first session because she said she hurts when she runs. So we didn't get her to do any running. That wasn't my intent. So what do you want to look at? What do you think is going on? What kind of the athletic training staff has been looking a lot. They've done a lot of stretching, a lot of strengthening the hamstrings, a lot of work around the hip, a lot of soft tissue stuff, like I said, and she'd been doing some cupping, had some dry needling done. Nothing seems to have helped her. So where do you want to start? What do you want to look at? What are your thoughts about diagnoses that might be going on? Is that pincer problem the primary issue? Is there something else going on? How do you check whether the pincer problem is a primary problem? Is that a concern for you as a therapist? Because MRIs find everything. So, is it something that's a concern or not a concern? So that's something there. So we decided we'd do an examination on her. So interesting enough, if you've heard other cases I've done, I always start in standing. And so I had her do heel walking and toe walking. Had no problem with either one of those. Did it evenly on both sides. Had no fatigue, no problems with that. She had no issues when she was standing in one leg stance. She had really good motion in both feet, very active in both sides. Didn't hurt her to one leg stand on the left leg, even though that hip was a problem when she ran. Didn't seem to be a problem when she was standing on it. Again, like I said, she didn't limp when she walked. What other things do you want to do standing? So anytime I'm doing any lower extremity anything, I'm always going to check the joints below and the joints above. We talked about some of those joints below we already looked at, but what about the joints above? Above the hip, that's the low back. So I always do a flexion extension series, and I do quadrants and do some side bending. And interesting enough, when she flexed forward, she deviated to the left. She deviated probably 15, 20 degrees. Okay. When she did extension, it bothered her some. Not terrible. She did quadrant to the left. She couldn't complete a quadrant to the left. It really bothered her to try to do a quadrant to the left. Posterior. Quadrant to the right, didn't have very much problem at all. So it was only left, and she deviated when she forward flexed to the left. Okay. So now we've got an issue. I can't rule out lumbar spine. When we start seeing those kind of things, lumbar spine, we've got to deal with that, right? So that's something we need to look at, okay? So we sat her down. We checked her range of motion, right? We want to check range of motion of the hip. Flexion was fine. Flexion was strong of the hip, okay? Abduction was strong of the hip. Adduction was strong of the hip, okay? Hamstring, she had a little weakness on the left side compared to the right. Had a little pain with that too. Not too bad, but it was painful. No other problems that were really found around the hip. Internal external rotation actually was pretty good on both hips. They actually externally rotated pretty well. So in sitting, we didn't find any weakness in any of the lower extremity stuff. We didn't find anything around the foot. We didn't find anything around the knee except for that one little hamstring irritation on the left side. Didn't find any kind of range of motion issues. Well, that's kind of interesting. You think a pincer problem, you're going to probably find some range of motion issues, especially rotation. Didn't really find those. So we next did supine. So in supine, she has a hip problem. I want to check some things that are involved in the hip and the hamstring, right? So I did a hip flexion. She was unable to go into flexion and adduction, right? So that's really typical for a pincer cam problem, FAI, right? But she had this exact same symptoms on the right side as the left. Exactly the same range of motion limitations, exactly the same pincer problems, exactly the same irritation in the anterior groin when you went into that adducted flexed position, exactly at the same moment. No change between the two. Didn't feel any different between the two sides to her. She had the exact same complaint on both sides. Has not had any hip issues on the right to date. Well, that's kind of confusing. That's not what I expected. So I did a scour. So a scour of her hip. Again, no real issues with any of the scour positions except for that adduction flexion position, which bothered her in the groin. Didn't hurt her on the posterior lateral joint area. It hurt her in the groin. That tells me it's probably not a hip joint problem. All other motions were within normal limits of the hip. I checked her strength around her hip, and internal external rotation strength were good. Flexion extension strength were good. Abduction, adduction strength were good in supine. Well, that tells us that I didn't find a lot around the hip. I'm looking, but I'm not finding much. Okay, except for that pincer. That FAI is there, right? And it's on both sides equally. So it's there, something to be concerned with. But I see a lot of women that have that. So when I was teaching the physical therapy program at University of Central Arkansas, we found about 30% of the women in the class had an impingement sign in their hips, and they were typically bilaterally. So I don't really, I don't know if that's something that's really concerned. She's a runner. She runs on a track. She doesn't do cross country. She's not a soccer player. She doesn't do any crossover steps. She doesn't do anything that's really. So this is the first time it's ever hurt her. I'm sure she's had it most of her life. Not sure that that's something that was staring at me as something. This is the issue. Okay. So in supine, I checked her hamstring flexibility. Interesting enough, when I checked her left hamstring, she had a pretty strong reaction to a 90-90 test. You know, when you put the hip at 90 and knee at 90 and you extend the lower leg, she had a pretty strong reaction to that. She had really bothered her, really hurt her in her posterior thigh, but it hurt her in her butt too. So, okay, is that hamstring? Well, how do we know it's hamstring or not? What can we do to make a difference in that? So we'll check that. We'll check that in another test in a minute, right? Something I didn't check at sitting, I probably should have. And we're going to go back to sitting and check it, okay? So I put her in sideline, and I decided to check her lumbar spine. So we did prone first on lumbar spine. We did PA testing. She had extreme pain when we got to L3 and L4. A little bit at L2. Okay? 5 was fine. Just really hurt her when we got in that L3 area. It just really bothered her a lot. So that tells us something's going on L3. Did feel stiff to me, but that's not my way of testing stiffness. So I did her sideline, and I checked intervertebral motion, doing a typical way you do it in sideline. If you don't know how to do that, it's a great little test that people that use it like it. People that don't use it, they probably don't like it as well as people who use it. But I found that it was hypomobile at 3-4 and 2-3. Those are the areas that were mainly tight. And I was like, okay, that's not what I expected to find, but it's there. Remember, she forward flexion, she deviated. So that's her, and quadrant test sort of told me it might be here too. So that's it. What's going on with the hamstring? So while she was prone, I checked her neural channel, I checked her sciatic notch, and I checked her upper hamstring, and she was really irritated neural channel. So I went back to sitting and I checked a slump test, and she had 30 degrees short of knee extension with a slump where she had a recurrence of all her pain in her lower extremity. And when she lifted her head, she had almost full motion. So it hurt her most when she was slumped, head down. When she lifted her head, she had increased range of motion. So that's a positive neural tension sign. And so her positive neural tension sign was there. She had lumbar spine hypomobility. She had no hip range of motion problems except for that impingement sign that was equal bilaterally. She had no problems with compression or distraction of the hip. She had no weakness in the lower extremity except a little bit in the hamstring on their one side. So what's going on? What do we want to treat? Why do we think that she has hip pain? Why does she have is it because of the FAI? Could be. Femoral acetabular impingement, or it could be. But they want to do surgery, and she don't want surgery. So what else could it be? Okay, so pregnant pause, right? We're just going to... Okay, so now let's just think about it. When I see a patient like this, what can I treat? What can I make an effect on that would have an effect today, not over a long time? So I could do a strengthening problem, but she didn't really have weakness. She's not really tight. But I could do those things, but it wouldn't have an immediate effect. It would have a longer term effect. So what could I do today that would make a difference? So what I did on her is I did a L1 through L4 manipulation technique. I actually got her back warmed up and loosened up and did some thrust techniques through her lumbar spine. She was really tight on the left side. Had a cathartic release when I worked through that area. Right side wasn't too bad at all. And that's what we did. So we were going to do some other stuff, but I decided let's check the slump sign again. So I checked the slump sign again, and her slump sign went away. So now she had full range of motion without having a positive neural tension test. Well, that tells me something right there that made it much better. But how about her hip pain? So I had her walk around and she said, I feel better. I had her do a forward flexion test where she deviated, she didn't deviate. Had to do a quadrant test, she didn't have any pain with quadrant. And so I got her on a treadmill and I had her run for 5 minutes on a 2% grade, so it's more like being outside. And I had her do it at the speed that she felt comfortable. She had no hip pain. So her hip pain went away. Did her FAI go away? No, obviously not. She still had an impingement sign on both sides, equal, still. That didn't change. But her hip pain went away. So let's go through this again. Why did I do what I did? The only thing I found that was wrong with her was her lumbar spine. We treated the lumbar spine. It was in the area that would refer to the hip. It was in the L2, L3 area, right? L3 is the hip. So could it be from that? Yes. What was the hamstring? Why was that a problem? Well, she had a neural tension sign. So when we got the lumbar spine working, her neural tension sign went away. So we had both things go away with just treating this one area. So we waited and sent her home and asked her to do a progressive running program. Continued to do the mobility of her lumbar spine. We had her doing some rotations and some other things to keep her lumbar spine moving. She came back a week later. She was running 4 times a week, no hip pain. Felt great, didn't have any problem. So we had her progress those runs, try to work on it. Saw her a week later, still no complaint. Discharged the patient. We think she's doing fine. I'll let you know if she gets bad again, but I think that's what it was. So this is a case of overdiagnosing. FAI was there, but it wasn't the reason she was having her hip pain. She did have a lumbar spine problem. Okay, and the lumbar spine issue was in the mid-lumbar area, mid to upper, and when we worked on that, it seemed to resolve her conditional problems, and she got rid of her functional limitations. So thanks for being with me today. I hope you thought through that with me. You can argue with me anytime you want to. I'd love to hear your emails and other things. I'm at steve@orthomti.com. My website is orthomti.com, and I'm at Facebook under the same name. Thanks for joining me today.